Hi, I'm Dr. Reza, Dr. Abbas Reza, representing International Society of Endocrinology, where I serve as the current president of the ICE. Definitely a pleasure to be invited by the organizing committee during this meeting. And I think the topic that I'm going to touch today is more on how we can incorporate different medications into the in use during the month of Ramadan. And I think one of the most controversial topics that we all, I think, in the diabetes world is the use of sulfonylureas, the safety of sulfonylureas. So I'm going to partly discuss today what are the positive outcomes of some of these sulfonylureas that we are using in this time and age. I'm going to present to you a study, which is a subset of study, which was done in about 3 years ago, called Ramadan study. And then we did the subgroup analysis of the people using combination of medication along with sulfonylureas. And I'll explain it to you as we go along. Interestingly enough, sulfonylureas are not new to our world. Starting in 1950s to 1980s, where we had the second generation and then the third generation of our sulfonylureas, all this along, I think one of the major contribution in SU was they were among the first medications to be used in the field of diabetes, oral medications. And again, their use have been extensively helpful in treating diabetes. And when we talk about studies, big studies in which we proved the cardiovascular safety data and the beneficial effect of controlling diabetes, we must remember the medication that was used during UKPDS was also a sulfonylureas or metformin or an insulin. So again, the data which has come out with decreasing the A1C and getting the benefit of it has always been part and parcel with the use of SU. And again, obviously, the newer medication are wonderful. They show much robust data as far as treating the complication of diabetes. But SU is something which not only is used in certain part of the world, but it's still used even in the modern world in quite a numbers, which we cannot ignore. Uh, with the SUs, I think the one of the biggest problems that we usually see is the stigmata associated with it, which includes the beta apoptosis, the causes of mortality, the weight gain, hypoglycemia, and obviously ischemic preconditioning, which again has been seen in the SUs use in of the older studies done in different part of the world. I think it is very important to know that not all SUs are the same. They work differently, they act differently, and they have different receptors as well as affinity towards the SU receptors. So if we clump all of the SUs together, probably we won't be doing a good cause for SU, because if you clump the older versions of SU and look at the data, probably you'll see more side effect. And I can quote you a number of studies in which, if we look at the use of glibenclamide, which is an older form of SU versus the newer sulfonylureas like gliclazide, there is significant difference in incidence of cancer and hypoglycemia and all the risk factors associated with the SUs. So I think it will be fair to say that we need to look at SUs in the current scenario as a modern. And again, if you have chance to go through an article or a consensus statement that we published a few years ago, which was safe and smart use of sulfonylureas, we go over each and everything as far as the safety of SU is concerned and the differences between the older form of sulfonylureas versus a newer form of it. This is not to undermine the point that there are certain associated side effects with SUs. But like with any other medication, we need to use it in a pertinent setting, and we need to be aware of the side effects associated with it. So without going into too much details of the SUs in the interest of time, let me just move right away to the study design, which was done in Ramadan. We included the people who were more than 18 years ago, who were already using a tablet, which was gliclazide MR 60 milligram. This was the study design that we wanted to see the safety of this molecule during Ramadan. And obviously, the people have to be on it for at least 90 days before the start of the studies. And obviously, they could monitor the blood glucose. People who were excluded from the study included if their A1C was too high, or if they were using insulin along with it, or if they had liver failure or a kidney failure associated, or they were associated with any contraindication for the use of glycolides. We divided the study in the initial Ramadan study in inclusion visit, in which people who were taking glycoside was included in it. This was followed up by the second visit, which included end of the study visit. And during this time, there was a period of 6 to 8 weeks before Ramadan, and obviously the during Ramadan and post Ramadan period. And people were asked to keep a record of their glucose diary, how they were doing, how many times they were fasting, and obviously there was a set of blood tests done before and after this pre-Ramadan visit, as well as the post-Ramadan visit as well. So very interesting in study. This was probably the one of the first study, real life study done on individuals with a medication, when seeing the effects of it, in apprehensive that probably will be seeing a lot of complication, a lot of hyperglycemia, if we are using SU in this subset of people. This was not a small study. We had about 9 countries associated with it. There were about 1,214 patients from across this region, which included India, Indonesia, Malaysia, and Bangladesh. And from the Middle East region, we had Pakistan, Egypt, Saudi Arabia, United Arab Emirates, and Kuwait included in this in this study. So interesting in a sense, it was a multi-center, multicultural study done in 9 different countries to look at the patient, how they will respond to if they were already taking a tablet called glycoside, and see if that's something we can have a positive outcome, and we can look into different complication of the medication during this meeting. We not only looked at the people, so the inclusion criteria included the use of glycoside. Obviously, everyone in this group was using glycoside, but it was interesting to know that there were a lot of people who were using other medication in combination as well, which included use of metformin with glycoside, DPP-4 with glycoside, SGLT2 with glycoside, even GLP-1s, A-carbos, and TZDs along with it. So this was a whole group of people. So in the interest of time, what we're going to see today is the role of sulfonylureas along with SGLT2 in a Ramadan setting, and we analyze this subset of group of people. To set one thing aside from the very beginning, the good news from the study was, and it was clearly shown in the study, that the reporting of hyperglycemia, which is severe, in which someone had to intervene to make sure that the patient was okay in case of hypoglycemia, was zero. So no one in the whole group had any severe hypoglycemia in which someone had to intervene. So this was a good news for us. And this is not going to be discussed in the second part of this presentation, because it's not something which was seen in this group. So the subgroup analysis would not be showing any severe group. So coming directly to the point, which is glycoside, MR, and SGLT inhibitors during Ramadan. Let's look at the patient profile. And again, we had about 102 people who would qualify for this subset of people. So these were the people who were using sulfonylureas as well as SGLT2. But they were also, in most of the cases, using a third medication, which was controlling the blood glucose. So it is important to know. So now we are not only looking at as SU, but we are looking at a combination of SU with SGLT2 and possibly metformin at some time or not. So we were able to find about 102 people. They were included in the study and they were used in the analysis as well. So they were about 8.4% of the total patient population. Not a huge number, but again, enough number so we can do a sub-analysis of it. I'm not going to spend too much time in patient profiling, but this is very interesting in know. So if you look at the whole in the whole study, and comparing it to 8% that we saw SGLT2 and SU use combined, surprisingly, these were a little younger patient group as well, which means they were, if you looked at the whole group, they were about 3 years on an average younger. But if you look at the studied disease duration, they were a little further away from the time of diagnosis. So 5.8 versus 5.4%. These were the group of in this group we saw higher incidence of dyslipidemia, we saw higher incidence of hypertension, and the BMI understandably was higher as well. So this subset of group of PM in which people were using glycoside, SGLT2, and plus minus metformin, these were a little bit advanced in the disease process, and obviously you would expect these people not to be, you would not only worry about managing diabetes for these people, but you would also worry about the possible complication of using medication, especially if you're using a triple regime. And these individuals also had a slightly higher A1C. So interesting subgroup analysis of these individuals as if we look at it. The other part that we also looked at, apart from looking at other factors, is that if you apply the IDF-DAR risk categories, although these individuals were a little advanced in the disease process, but most of them fell in the moderate risk group, which was good in a sense that we selected these people were included who were not at a very high risk of hypoglycemia. Obviously, these were not the individuals who was using insulin or having recurrent hypoglycemia, but they were not a low risk. Not all of them were only low risk because they were using complicated regimen, which included SGLT2 and metformin as well. How many of them were advised to fast? Most of them have been advised by their doctor to go ahead and fast. And at this time, I would like to say that we have evolved in the medical community from the time that I remember I started practice, when we used to say that any diabetic should not be fasting, to the time now that we are putting the people in a high risk, low risk, and moderate risk, and we are actually allowing people to fast again, which is an amazing journey for me as an individual, because I remember coming on the podium and saying that all the people with diabetes probably should not fast, or especially people who are taking hypoglycemic agents like SU or using insulin should not be fasting. But now with these studies like this, we are able to say that go ahead, fast with these precautions. So this study is just another contribution in that direction, that people who are taking dual treatment or a triple treatment could fast with safety. If you look at the SGLT2 treatment, apart from the glycoside that they're using, most of them actually 90 plus, 87%, 97% of them were using either dapagliflozin or empagliflozin, which is the predominant SGLT2 available at that time in most part of the world. There were few group of people who were also using canagliflozin. So again, this data is a very good mix of people using dapagliflozin and empagliflozin, which probably still are one of the most used SGLT2 in this part of the world. Um, so let's look at the crux of this whole study and see if we were able to make any impact, or if we were able to see any significant problem. Whenever we look at the risk of hypoglycemia, whenever we want to look at the risk of making sure the patient's safety is there for during Ramadan, we always look at three or four parameters. So one of the major parameters is the severe hypoglycemia. That someone is using the medication had to use the intervention from someone else outside the himself being able to treat a hypoglycemia. Someone has to intervene to make sure that he was okay. But again, from the get-go, I've already informed you that these individuals did not require any intervention as far as severe hypoglycemia is concerned. So if you look at the Dire Ramadan study, the safety data was amazing. If you look at the whole group between the SU users, we saw about 2.2% symptomatic hypoglycemia. 1.6 had confirmed, in which they checked it and they found out that they have hypoglycemia. But the good thing was, traditionally, we always see an increase in A1C, we see an increase in weight, we see increase in fasting blood glucose and prandial blood glucose. In this study in Ramadan, we saw symptomatic hypoglycemia and confirmed hypoglycemia, which was in a very reasonable way. So let's see what does our subgroup analysis show as far as when we look at the SU and SGLT2 use and probably a third medication metformin use in these individuals. Triple or double, at least triple regimen use has shown it, and the results is actually also encouraging. If you look at the people who experience symptomatic hypoglycemia, which was 7.8 traditionally, if you look at the studies, this was very acceptable as far as if you were able to diagnose and able to control it during Ramadan, especially if someone is using three medication or two medication list. And if you look at the confirmed hypoglycemia, it was slightly high. So it was a little higher than the people using probably the metformin only with the glycoside, but it was still in the range which was accepted. And remember, there was no severe hypoglycemia even in people who were using three or four medication, which included glycoside and SGLT2. Amazing. And the good thing at the end of the day is that they were still able to reduce their A1C to less than 0.06, to almost to less A1C of zero point 0.6 was less as the end of the study as compared to the beginning of the study. And in addition, their weight was also lower at the end of the study. Ramadan is a time that we usually feast as well, so we tend to gain weight. And the other reason we tend to gain weight is the risk of hypoglycemia. When you're experiencing hypoglycemia, you tend to eat more and you gain more weight. So all these worries were actually addressed in this subgroup analysis, and it was wonderful to see that the people did fairly well in using this medication. So hence, this subgroup analysis further enhances our worries, or actually it helps us understand better if someone is using the three medications during Ramadan, they can fast safely. And again, it takes care of lots of worries that the patient or the physicians have in their mind when they're asking someone to fast while using these medications. With that, I would like to thank you all for your kind attention. I'll be available to take any questions if we have time allowed. And again, it was wonderful presenting you some of very interesting data which was seen during the Daya Ramadan study. Thank you.